Thank you both for the great presentation, and there's a lot of questions, but actually you covered a great deal of them during the talk. So it's almost like you were reading the questions and then getting to the answer in it. There are a couple about OFEV and nintedanib, and I guess asking when you're using it, what your experience with it is. Do you let the pulmonary people do it, or are you doing it? What would you say to that, Jeff?
Well, it's good to see everyone too. Yeah, I think this has been a huge development over the past few years. Certainly in our group, we're immersed within the pulmonologists, so they are pretty involved in helping us to decide. And I think for the most part, we are using it a lot in UIP that's sort of above that threshold of clinical significance. And I think the experience has been pretty similar to IPF, where there certainly are some patients that can't tolerate it related to rash and diarrhea. But in those that do tolerate it, it seems to at least stabilize their disease and maybe even improves it in some.
Jack, what do you think?
I think this is still going to be a drug that's in the hands of the pulmonologist, and I think in the hands of rheumatologists who have a real autoimmune lung interest, and that people like Jeff and Paul Della Ripa and others who are really leading this area for us as the troops in rheumatology. I think we need to have people like Jeff and others and our pulmonary colleagues. Often there's pulmonologists who specialize in autoimmune lung disease, and I think that between us we can identify the patients. But I do believe that's largely going to be the script written by the pulmonologist more so than myself. I'm willing to do it. I personally have not yet written a script for nintedanib. Or is it called Nintendo?
Super Nintendo.
There you go.
Super Nintendo. Great. So there's a couple of questions about the atypical mycobacterium. Is one about looking for them. The other is, what about treatment in someone who's had a history of atypical mycobacterial infection? Jack, you want to start out?
I think you look for it when you have a chronic lung condition and/or extrapulmonary. Remember, extrapulmonary manifestations of mycobacterial infections are common in patients on biologics, but I can't underscore enough. It's TNF, 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 and then maybe another biologic or another mechanism. You need TNF to make granuloma and maintain granuloma. You inhibit TNF, that's where you get into trouble with mycobacterial and fungal infections. So yes, this can happen with abatacept and rituximab and maybe a JAK inhibitor, but pound for pound, this is all a TNF story. The point being, if someone's had a prior, unlike TB, if you have treated TB, whether it's latent TB or active TB, if it's treated, they can go back on a TNF inhibitor. No problem, not at all. But atypical mycobacteria, you do not fully resolve those infections, and you really can't. And luckily for you, you've got 14 other drugs and 22 biosimilars to choose from, but just not a TNF inhibitor. Just use another MOA in those people. For the people who you must use a TNF inhibitor, which I don't know who that is, you would have to go on background, zithromax therapy to prevent the atypical mycobacterial infection. But I think everybody would advise avoiding TNF inhibitors. You can use other biologics, though.
Jeff, anything to add on that?
I think I think we get into these chicken and egg scenarios with the NTM, where it can look really very similar to bronchiectasis that could be sort of due to the underlying RA, or maybe the infection sort of trashed the airways. I think that's kind of the quandary I get into is like, was their RA lung disease the risk factor for getting it, or was the infection, kind of causing structural abnormalities, and how that puts the patient at risk down the line. But I agree, offloading the TNFs is really the first thing to do.
But I think Jeff's point is a real good one. It happens in people who have structural lung disease. Sometimes the interpretation of whether it's an active NTM infection or not is really difficult. And this is the ATS, the American Thoracic Society, has dealt with this. They have guidelines. There's a big problem of colonization that you don't need to always treat, just because you get an atypical mycobacterium. So in these situations, you need either a very experienced pulmonologist and/or IED specialist who knows the ATS guidelines on who really does need to be treated for a non-tuberculous mycobacterial infection.
Here's one for Jeff. About azathioprine in the treatment of ILD and RA. You mentioned mycophenolate.
Well, I think I touched on this related to that Panther trial that had, the poor outcomes in the arm that was prednisone, azathioprine, and acetylcysteine. And again, we're immersed in the pulmonology group, and they really have backed away from using azathioprine related to that study. And then in the converse, we've been, again, having an image makeover for some of our other conventional synthetic DMARDs, where I think this is a big change. 10 years ago, you might have switched them from methotrexate to azathioprine just because it felt lung-friendly, and it's really the exact course sort of right now. But certainly there are some patients that you might need to use it where you've really exhausted some other options, and they have some, it does work for joints, so there are certainly situations where you might consider it.
Jeff, what's your opinion about the reports in the literature, historic more or less, about RA-ILD being brought on by leflunomide or by TNF inhibitors? I think sometimes we rheumatologists get saddled with that impression, either from the literature or from our colleagues in pulmonary.
Yeah, I didn't touch on it, or I'd still be talking. But yeah, I think leflunomide, we've already talked about methotrexate quite a bit, but leflunomide and TNF inhibitors seem to be the other RA medications that have that at least perception. And I do think it's a little bit unclear, but I've had a few patients where you start TNF and they start coughing and they have a lot of lung inflammation that doesn't seem to be pneumonia. However, we did a study trying to really look head to head, and there didn't seem to be a difference as far as observational studies. I do typically, given all the other options, I don't necessarily want to start leflunomide or TNF inhibitors, and often they've already been on those meds in the past by the time the RA-ILD has been detected.
All right, we have a question here live. Dr. Fung?
Yes, about the leflunomide, actually, I have one time the insurance would not pay for it because they say there might be a problem with the interstitial lung disease. And I have reviewed there are about 200 cases, and they say leflunomide have not increased ILD. And so the insurance finally approved it. But actually, that's not why I'm not here. Okay. And my question is for you. You talk about the bronchial alveolar lavage or biopsy. Now, you wisely show up. The good radiology will tell us whether that is, NSIP or UIP. So do we need to go on to lavage or biopsy? If we have finding something like LIP or, BOOP, would that make a difference for how you treat the patient?
Well, I think I do agree that the lung imaging it seems to be the expertise, and maybe the actual images themselves are of higher quality such that we're doing less biopsies and BALs. But having said that, these are complicated patients that are immunosuppressed, and they can have more than one thing going on. And I'm sure everyone has their anecdote of something where you thought the lung imaging was inflammatory or infectious, and it turned out to be cancer. So, I think you have to have your antenna up, and, there's sort of a sweet spot where you need to be biopsying enough to catch all the cancers, but not too much where you're causing the complications. And this is why it's a multidisciplinary approach, and it's not a one-size-fits-all solution.
Yeah, Gene, I think that in these people, I like more information. I know that the things you talk about, biopsy and lavage, are kind of invasive and whatnot, but these are the things we're considering here are never mild. These are bad patients, and I think sometimes more information might be better in these kind of situations. But I think it's always going to be a tailored kind of answer depending on the case.
Yeah, so the point is we want to rule out something else. But I think the pathology, now having a BOOP, having a DAT, having a LIP, would that make a difference how you treat them? Do you know any better treatment of LIP versus UIP?
No, I'm handing that off. I did my job to disclose what's on the table, and now It's either Jeff or the pulmonologist is going to manage that, not me.
So Jeff have an answer for it?
If you knew it was BOOP or LIP, would it change your treatment?
Well, I think it's typically trying to make sure it's not UIP and how, what is really causing the clinical symptoms and the hypoxia or whatever is bringing them to you. So I think it's a bit hard to answer, but certainly there certainly are patients where the imaging is enough and you can treat appropriately. And certainly if things don't go as you expect, if they're progressing through your treatment or, those are patients where you re-image and maybe think about a biopsy.
I think in those days, they talk about the ravage. If you see a lot of desquamation, that might mean you have more inflammatory disease. Do you still believe that's true?
More inflammatory disease
Yeah.
with more desquamation?
Yeah, when you see more desquamation on the bronchial alveolar lavage.
Oh. Yeah, the pulmonologists really get in the weeds about that. I let them try to figure that out. I think I'm trying to rule out infection and hemorrhage usually.
So how about, this came up, you're talking about RA patients with dyspnea. What about the pulmonary hypertension workup? Where does that fit into your algorithm? Jeff?
Yeah, it's on that long list of differential diagnosis considerations. It's not as common as systemic sclerosis, for instance, but certainly there are some patients that seem to have pulmonary hypertension and right heart failure, maybe even unrelated to RA. They're just someone that happens to have that and RA. So I think you got to keep an open mind and be a good medicine doctor.
Okay, yeah, another question?
So I have a question about the biopsy. When would you consider doing one? I mean, after they failed, say, something like azathioprine and or mycophenolate, or would you proceed to rituximab before you did a biopsy? And what kind of biopsy are we talking about? A transbronchial or open lung biopsy?
Yeah. Well, I mean, you can think of basically two types of patients. Ones that are really very clearly RA-ILD of a particular subtype, and you treat them and maybe they progress and maybe they're not going well, and you're just very convinced that you really know what you're dealing with and you switch therapy. Honestly, I think the messier patient is more common. They're a smoker, they've got COPD, they've had pneumonias in the past, they have a viral syndrome now, maybe they had COVID, and they've got risk factors for everything. So, that's when you would probably consider some procedure. And as far as the type of procedure, I don't think the transbronchial biopsies have really been that helpful. But obviously the other types of biopsies are more invasive. So certainly, sometimes the pulmonologist will do a BAL while they're there, try to do a transbronchial biopsy. It's typically not diagnostic. And then it's a bigger decision about, getting more tissue with a, more of an ordeal.
Okay.
And it buys you some time too.
JAK inhibitors and RA-ILD.
Yeah, I didn't put that on my list there. I think the jury's out. I mean, obviously a lot of patients are getting treated unwittingly because of the, predominance of subclinical findings. I haven't really seen a lot of literature, plus or minus, about ILD with JAKs. Have you, Jack?
No. I mean, and if anything, maybe you could say that since JAKs have been on the market since 2012, I might have expected to see some sort of hint at this point that might have been a part of the spectrum of their benefit. Instead, all the benefit seems to have gone to baldness and eczema.
So a lot of questions and re-questions about the screening. You mentioned this, Jeff, and you said you do a chest X-ray as baseline, even without symptoms, and then the rest of your workup really will be based on symptoms, but asymptomatic, nothing beyond a baseline chest X-ray.
When starting methotrexate.
Yeah, RA asymptomatic from a pulmonary standpoint. Mm-hmm. Okay.
Yeah, I don't do PFTs until they start saying I'm short of breath, and that's usually my first two steps is a chest X-ray, maybe a repeat chest X-ray, and then and then getting PFTs to see what we're dealing with and whether they need to be in my hands, an allergist's hands, or pulmonologist's hands.
And Jeff, do you have any sort of PRO that you use, or is it just part of your routine to ask them about the pulmonary symptoms?
Yeah, we aren't really systematically implementing dyspnea screens. There are a few that are pretty easy to do. I think the problem is almost all RA patients are positive for it, so it's too sensitive at this point. And there's a large battery of questions we do for research that are not practical for clinic.
Can I ask you a question about 6-minute walk time? One, can you bill for it? Two, can you send the patient for a 6-minute walk and see 2 other patients while they're walking and you're making money? I mean, it just seems like an odd kind of diagnostic or assessment test. Do you think it has utility for us rheumatologists?
I don't bill for it. I don't know if you can. I should probably figure that out by now. I don't think you can consider the hallway another clinic, granted.
All right. Well, thank you very much, Dr. Sparks and Dr. Cush.